Good afternoon. This afternoon, I'd like to discuss the recommendation for our cardiopulmonary clearance. So ideally, a cardiopulmonary evaluation or clearance is performed for all patients undergoing a diagnostic or therapeutic procedure. So a thorough history and a good physical examination are all that is necessary in a healthy child undergoing an elective, low-risk surgical procedure. It is still the best means of preoperative screening. Included in a complete medical history are the indications for the surgical procedure, known allergies, medications, especially those that are over-the-counter medications like aspirin, anticoagulants, diuretics, and ACE inhibitors, known medical problems that might affect the surgery, kidney disease, liver disease, seizure disorders, etc., and the surgical history, any past operation, including previous anesthetic experience or response, cardiac status like presence of shortness of breath, cyanosis, exercise intolerance, history of either a congenital or an acquired heart disease, the pulmonary status, respiratory problems, wheezes, history of asthma, hemostatic status, past history or family history of anesthesia problems or bleeding, and possible pregnancy. A complete physical examination will include the height and the weight, the vital signs including the heart rate and regularity, the respiratory rate, blood pressure of both arms, the temperature, a complete pulmonary evaluation looking for rales or wheezes or decreased breath sounds. Okay. So next, we have to determine through the cardiac evaluation the presence of a murmur, whether you have an innocent or pathologic murmur. Noted pathologic murmurs would be diastolic murmurs, pansystolic murmurs, loud murmurs, or continuous murmurs. Also determine if there is any decompensation or heart failure. Included in the cardiac evaluation would be to determine the presence of significant arrhythmias documented by ECG, examples of which are high-grade AV blocks, ventricular arrhythmias, or supraventricular arrhythmias. Likewise, it is important to determine if there is hypertension and the presence of congestive heart failure. Determine also in the cardiac evaluation the need for endocarditis prophylaxis. So here are the indications for IE prophylaxis. Pertinent laboratory evaluation should be requested. Among the laboratory tests obtained are based on the patient's underlying medical condition and planned surgical procedure. More than 95% of patients having elective surgery require no testing before the procedure if they are without active illness or unstable chronic illness documented by a good history and physical examination. The most common laboratory test requested is the complete blood count. Hematologic screening of healthy children before elective surgery is unnecessary. Anesthetic management in the post-operative course would not be significantly affected by mild anemia, a hemoglobin of more than 9.5 grams per liter. Asymptomatic mild abnormalities of the WBC platelet counts have no impact in the perioperative period. The only time that a hemoglobin is determined is when there are significant anemia of less than 9 grams per liter, and these are suspected in infants less than 6 months, ex-premature infants, those with chronic illnesses, those with a history of recent blood loss, and or hematologic screening is done to determine anticipated significant surgical blood loss. Another lab test done, the coagulative screening of prothrombin time, partial thromboplastin time, and platelet and bleeding time, do not reliably predict perioperative bleeding. Tests should be considered only in patients undergoing procedures with a high risk of intra or post-operative bleeding, those surgical procedures that require adequate hemostasis like tonsillectomy and adenoidectomy, those procedures wherein minimal bleeding will be critical like neurosurgical procedures, those undergoing cardiopulmonary bypass surgery. Coagulation screening is also done for patients that will have possible clotting disorders, those with a history of large bruises or hematomas, those with prolonged epistaxis or unusual bleeding after dental extraction. Patients also who have a history of ingestion of aspirin or anticoagulant medications, or those patients with jaundice or liver disease need coagulation screening. Blood chemistries are not routinely requested because electrolyte imbalances of any consequence are extremely rare in healthy children. Preoperative screening of such deviation is usually unhelpful and does not alter the anesthetic management. Blood chemistries are performed only for specific indications like patients on diuretics, patients with renal insufficiency, or patients on nasogastric or gastrostomy feeding tube, or those on prolonged parenteral nutrition. An important laboratory test that may be requested would be serum albumin, as a low serum albumin level of less than 35 grams per liter is a powerful marker of increased risk for post-operative pulmonary complications and should be considered in patients with one or more risk factors for perioperative pulmonary complications. Malnourished patients experience a high surgical morbidity and mortality. Likewise, urinalysis is not routinely determined. Routine urinalysis is insufficiently sensitive and too nonspecific to be of clinical utility in detecting a symptomatic disease that would have an impact on perioperative management. Urinalysis is indicated in the presence of known renal or bladder abnormalities. The chest x-ray is sometimes requested, but clinicians can predict most abnormal preoperative chest radiographs by history and physical examination. Routine preoperative chest radiographs in well children have failed to detect abnormalities of major anesthetic or surgical consequences and are not necessary. Likewise, an ECG is not routinely requested unless there is no ECG in the past year for certain patients with congenital heart disease, patients with congestive heart failure, patients with diabetes, hypertension, chest pain, peripheral vascular disease, patients with inability to exercise, with morbid obesity, patients with OSAS, patients with bronchopulmonary dysplasia, and patients with severe scoliosis. So in summary, this is my recommendation. A thorough history and physical examination are still the best means of preoperative screening and is all that is necessary in elective, low-risk surgical procedures. Laboratory tests are obtained based on the patient's underlying medical condition, age-related risk, and planned surgical procedure. The clinician may predict most abnormal preoperative chest radiographs by history and physical examination and should not be used routinely for predicting the risk for post-operative complications. Likewise, an electrocardiogram is not necessary for routine procedures unless a specific indication is present, like diabetes mellitus, hypertension, congenital heart disease, congestive heart failure, peripheral vascular disease, obstructive sleep apnea syndrome, bronchopulmonary dysplasia, severe scoliosis, morbid obesity. Laboratory tests other than those indicated by the history and physical examination are not cost-effective, do not provide medico-legal protection, and in fact may harm the patient. The primary goal of a CP evaluation is to identify patients at risk for peri- and post-operative complications, to address these medical issues, and to ensure a successful outcome. Preoperative basic health assessment is done within 30 days of the planned surgical procedure. No new clearance is necessary if there has been no interval change in the patient's clinical condition. So this is just the flow diagram of how you would go about the CP clearance. So decide whether this is an elective procedure. An elective procedure, if this is a high-risk procedure, prolonged surgery, complicated surgery, then this falls out of the guideline. But if this is a routine surgical procedure, a preoperative basic health assessment will include only a medical history and a physical examination. If there is any abnormal finding, then you can do necessary laboratory tests based on the abnormal findings. If there are no significant abnormal findings, then you proceed with the surgery. If there is an abnormal finding, high risk patient, then you manage the high risk. So if there is hypertension, morbid obesity, diabetes, then you address this and then proceed with surgery. High-risk procedures would be those that would have 5% combined incidence of morbidity or mortality. So less than 5% would be a low-risk procedure. Any major cardiac or non-cardiac thoracic procedure would fall out of this guideline, and surgeries that are prolonged, generally longer than 2 hours or associated with large fluid shifts and or blood loss would be high-risk procedures and would fall out of the guideline. Okay, these are just the list of preferences for where I got my data. Thank you.